at what we are expecting from our data. And so basically what we are looking at when we just measure the things. And the first, I think, questions we have to assess is my patient in shock, and is perfusion of the tissues adequate? And for this, of course, we have multiple means to use, and of course, it's not that easy. I mean, if we just discuss the definition of shock, is like definition of sepsis. It's something which is sound, but not very practical at the bedside, because indeed, it is insufficient delivery of oxygen to the tissues to provide their basal needs, and which results in cellular dysfunction. Wow. How do you translate this into your practice? Indeed, it's not very easily. Oh, you may say, okay, I will look at VO2, DO2 relationships, and of course, this is something that you can do. But remember there, we have several factors you can look at the bedside, and perhaps we have indeed the clinical signs, we have SVO2. We just discussed SVO2 here. Remember that SVO2 will drop well below the point when we reach this value of what we call shock. So for this, lactate is much better because indeed it rises at this point here. So we really need to integrate differently SVO2 and lactate in this condition. How to evaluate at the bedside this VO2-DO2 relationship? Well, we cannot really do it. So we have basically three different variables. SVO2, I already mentioned that SVO2 is much more the balance between oxygen delivery and the actual consumption, but not really the evaluation of shock itself. So we are left with the lactate and the PCO2 gradient. And so the lactate, we have many data showing that indeed it is associated with a poor outcome when it is increasing. Also that when it changes over time, it's also something very important. So when you do an intervention, you are more happy when you see a decrease in lactate level because mortality will be lower than when you see an increase in lactate levels. And also one of the very important questions we have at the bedside, is it always of hypoxic origin? And for this, of course, one of the ways maybe perhaps to look at the lactate to pyruvate ratio. And in this trial, what we did is indeed we did it on admission, and you see that most of the elevated lactate were indeed associated with an elevated lactate pyruvate. But over time, this changes. So I think that when we think at integrating the variables, we need to take time into account, and on the admission on early hours, when you see an elevated lactate level, you may think, yes, this may be shock. Later on, 2, 3, 4 days, forget about it. It's not really a marker of hypoxia at that time anymore. PVCO2 variables, we cover this several times. Just, is it just flow? Is it anaerobic metabolism? It can be both, and this is really the problem. It is indeed inversely related with cardiac index. It is also inversely related to microvascular perfusion. So as such, it is a very good marker of perfusion. But the question is, can we really take this as a marker of hypoxia? And probably not. And for this, we have to have something which is a little bit more elaborated. And of course, it needs a computer because indeed it's gradient between PVCO2 and PaCO2, but you divide it by the arteriovenous difference in oxygen content. So a little bit more complicated indeed to do at the bedside. And this approximates the respiratory quotient. And for this, a very nice trial here from Jean Teboul group showing that indeed, when this gradient is elevated, for the same increase in oxygen delivery, you have an increase in oxygen consumption. So we're on steep part of this relationship compared to when you have exactly the same increase in oxygen delivery, but no change in VO2, and in this case, this gradient is normal. So this gradient may help you to identify patients with an increased, with an anaerobic metabolism. And so this may be something to use at the bedside, combined or not with the lactate levels. I will rapidly burst over this. So when we are discussing the different aspects, is my patient in shock or is tissue perfusion adequate? We have really 2 or 3 different aspects. And for the is my patient in shock, we just need to look at, or we can only, look at markers of anaerobic metabolism. Either lactate, but with the drawback we have for this, or using this ratio, which approximates the respiratory quotient, and which is probably one of the most reliable we have at the bedside now. The second aspect we have indeed to discuss is perfusion adequate or not? And for this, we have several different other aspects. We have SVO2, as already mentioned, but so we can be without any shock, but still perfusion inadequate, of course. We can look at markers of organ function, urine output discussed earlier on this morning, capillary refill time, mottling, and others, and the mental state also, which is, of course, initially easily to assess, later on often less easy when your patient is intubated and under sedation. And again, the PCO2 gradient, which is a marker of flow and not a marker of hypoxia in itself if you use it at that point. The second very important aspect that we ask from our hemodynamic monitoring is that when we identify that the patient is shock, is what exactly is the type of shock. And for this, it's quite easy. We have only 4 types of shock. This is the hypovolemic shock, which in the first hours of presentation in the ED is probably the most frequent, but later on will disappear or minimize. Then we have the cardiac shock, distributive shock, which are the most frequent we see in the ICU, and then, of course, the obstructive shock. And to make the difference for this, we have to integrate several variables, but the first is probably the flow of the cardiac output itself. When it is high, it can only be distributive shock. We do not know exactly the source of the distributive shock. It can be septic shock, can be anaphylactic shock, can be many other types of distributive shock, but it is distributive shock. When it is low, then we have to identify tamponade, or we look at pressure volumes using several types of monitoring. When these are low, it is hypovolemic. When these are high, it is either obstructive or cardiogenic. So this is a way to approach our patient, which is a way very easy, and that indeed will help us to identify what is exactly the type of shock in these conditions.
Daniel, may
Yes.
I interrupt you?
Yes.
1 second. You know that in many cases we have different anomalies and combination of anomalies. So this makes things a little bit complicated.
It makes things a little bit more complicated,
Hypovolemic plus,
but you have to have a stepwise approach. This means that you have always one dominant over the other one. This means that what you will do is one step, you do my assessment now, this is the dominant factor. If I see a patient with a very low cardiac output, this will be this type of shock which is dominant now. If after giving fluids, it's transformed it into a distributive shock, this is something, of course, totally different at that time. But then, of course, this doesn't mean that you cannot give antibiotics to a low cardiac output state. This is something totally different, because indeed you have the other aspect, which is the hemodynamic abnormality, which is dominated by the hypovolemia, or which is dominated by the cardiogenic aspect. You may have a septic shock with such a huge myocardial depression that your patient may present with a cardiogenic shock type and will end up under ECMO. So this doesn't mean that this patient will not receive antibiotics. He should. So in the way you will treat your patient with the causal aspect is something a little bit different. For the hemodynamic approach, this patient with a cardiogenic shock due to sepsis will be treated as a cardiogenic shock and probably will not respond to fluids, will not respond to other things like this. So it's really the key dominant factor of the hemodynamic pattern at that period of time. And again, this may change half an hour after when you have treated this component. So I come to my first question. We measure a cardiac index at 3.8 liters per minute per square meter. We see some pulse pressure variations in this mechanically ventilated patient at 15%. What is our likely diagnosis? Is it hypovolemic shock, tamponade, distributive shock with fluid responsiveness, pulmonary embolism with acute right heart failure, or cardiac shock. I have to. We can vote. I mean,
They are voting, but do you want to read it?
okay.
Okay.
Just tell me.
And then you will change.
But just tell me what I have to do, please.
Go on. Yeah. Go on. No, I don't want to change the answer.
And tell me when I have to stop.
12 people.
Okay. So,
This is, yes, this is what you said.
Yeah, that's why I told you. Do you want to
no.
on this and
Because people are influenced,
Yes.
by the results.
So I think that the majority of the people got it right indeed. We have a high cardiac output, so it is distributive. The post-pressure variation can be indeed, and this was a little bit the intent of the question, the post-pressure variations can be observed in all the type of shock. Almost. I mean, you can have it, of course, in hypovolemic shock by definitions. You can have it in tamponated pulsus paradoxus, of course, also. You will have it in pulmonary embolism because, indeed, this is the acute cor pulmonale, and this will lead also to these respiratory variations. And you can have it less in cardiac shock because in pure left heart failure, you will not have it. But because we have a high cardiac output, we have, you can get up to 100%, I guess. You have indeed.
It's a way to measure the efficiency of that.
But because we have a high cardiac output, this cannot be hypovolemic shock, because indeed the cardiac output is high in these conditions. We may have, of course, some hypovolemic component, but the distributive component is much more important here. So indeed, it is distributive shock with fluid responsiveness in this patient. So you are right. So the question now is how to really assess this at the bedside, and our society or our societies go all in the same direction, that indeed echocardiography is really one of the way to go there, because indeed it helps to really easily have this kind of diagnosis made, and perhaps not only you see it rapidly at the bedside, but also it's concordant diagnosis made in a very rapid time, 5 minutes on the average, and this cannot be done with other techniques. Admittedly, we like to have other measurements in addition, because indeed it is not that easy to follow several patients in your unit at the same time with echo. You do not have enough hands to do this. So indeed, often we have additional measurements to have the follow-up, which is nurse-driven at the bedside. So we know we have this point, which is indeed solved. The next, and perhaps the most important aspect, is what is the adequacy of cardiovascular function. And just to begin with, I mean, we have rapidly identified with our usual clinical evaluations that tissue perfusion is inadequate, but we do not know exactly what is the cause of this abnormality. And I think this is really something we need to keep in our minds, because sometimes we hear that, oh, there were no randomized trials showing that there is a benefit with any of the monitoring techniques we have at the bedside. And that's true. But we need still to realize that if we just go for nihilism, being just using the clinical science and so on, we will be really in trouble, because we have real difficulties to clinically guess what is the level of cardiac output, what is the cardiovascular function of our patients. And so when we want to look at the determinants of tissue perfusion, we need to think that there are several different steps. It could be cardiac output, it could be the perfusion pressure of the organs, and it can be the microcirculation. To be at the perfusion pressure of the organs, it can be just a mean arterial pressure we may discuss, but also we have to discuss the output pressure, or more importantly, the interstitial pressure, because one of the two may sometimes be the most important. Sometimes for the brain, it will be indeed the ICP, which will be the determinant of the driving pressure to the organ. For the kidney also, sometimes it is. For the abdomen also, with raised intra-abdominal pressure, sometimes much more than the CVP itself. And sometimes it could be the CVP, so we really need to think at one or the other one as very important factors. So when CVP is low, when we have no raised intra-abdominal pressure, when we have no intracranial pressure, indeed, just mean arterial pressure will be the determinant of perfusion pressure to the organs. But much more than just cardiac output itself. The most important question we have to address is cardiac output adequate, yes or not? And for this, we have, again, what we have already mentioned, SVO2 markers of organ function, meaning not only SVO2 itself, because of course SVO2 is just one of these factors, but just the other factors like passing urine, vasoconstriction, yes, now, and mental state and other signs like this. And so the list is quite long. I will not limit myself here. So we measure this cardiac output at 3.8. We know that pulse pressure are 15%, but now we measure the SVO2 at 60%. And the lactate is at 4.2. What is our interpretation now? The patient is in shock due to the high lactate level. The cardiac output is normal. The cardiac output, even though elevated, is still inadequate. I don't care about SVO2. The goal-directed therapy trials have shown that it has no value it doesn't improve outcome. And I don't care about lactate because my patient has a high lactate level, so at the end, at the high cardiac output, then the lactate is not really important here.
Do you want to show and then you influence?
So now it is 50. So I anticipate that this will increase and this will decrease.
Usually, yes. So it's so indeed, the cardiac output is relatively high. My patient is indeed in shock, but we knew it already from the first evaluation that indeed it could be, but lactate alone, again, when you do not know exactly what is the time at which we measure it, we cannot really be sure that it is lactate of a hypoxic origin. So we need to be cautious about this, because I did not make any precision on when was measurement taken. Cardiac output is normal now. It's elevated cardiac output. Elevated and inadequate, yes, of course, because we have both SVO2 low and increased lactate levels, which is together, when we take these all together, it's something we need to take into account. SVO2, SVO2 has an intrinsic value to evaluate the cardiovascular system. We don't discuss the value in terms of outcome and manipulating the SVO2 in isolation, but nevertheless, the SVO2, when it is low, it means something for your patient, and you should not neglect it, of course.
So this is because SCV2 is low that you can answer cardiac output is not adequate.
Exactly.
Is it clear for everyone? This is why it is important to measure SCVO2 or SVO2, because it can tell you about the adequacy of cardiac output. Here, it is inadequate, even elevated. This is what Daniel said.
Yes.
Just a point about lactate. What about lactate clearance?
So lactate clearance is something that occurs in the liver. Lactate decrease is something that we see in our patients. No, what about lactate decrease? It's even, it's as important as a snapshot lactate. When you have an elevated lactate, it's always a red flag, but knowing where it comes from and where it goes, it's even more important, of course. In the interpretation of being adequate or not, doesn't change a lot. Yes, please. Microphone, yes.
Can you comment on the usefulness of lactate in someone who's also got concomitant liver failure?
Well, so basically, unless you have acute necrotic hepatitis, the lactate has to come from something. So the first time you see your patient, an elevated lactate level suggests that something occurred. The problem, you do not know exactly when it occurred. It could have been right now, it could have been 2 hours before, because indeed the lactate clearance in this condition indeed is decreased because of the decreased lactate function in patient with cirrhosis. But a normal, let's say, a patient with a cirrhosis walking in the street here in Hong Kong has a normal lactate level.
There was a paper by Jean-Louis Pourria in The Lancet 20 years ago showing that even in cirrhosis, lactate can be normal. So how to say, liver failure is a contributing factor to increase lactate, but not the major content.
Again, I mean, the acute necrotic hepatitis is indeed as such leading to a lactate, but otherwise there is no real lactate production by the liver itself.
We also, Daniel, we know that from hepatic resections.
Yeah.
You know, in that you can take 60% of the liver out.
Yeah.
You get a blip in the lactate, and then within 12 hours it's back to normal.
Yeah, exactly. So, the next step to have in our way to interpret the things, we identify the lactate that cardiac output is inadequate, and then we have to know: is it preload effect? Is it contractility? Is it afterload? Or is it heart rate? Heart rate is usually relatively rapidly identified. I mean, it has to be within a reasonable range, of course. We have a little bit more trouble with tachycardia than with bradycardia. Bradycardia is easily identified as something totally abnormal. Tachycardia, we know that the normal response is to be somewhat tachycardic when you have decrease in stroke volume. At some point, of course, when you have excessively tachycardic, you may restrict the diastolic time and have some impact on the feeling also. For the preload, I will roll rapidly here. We always all know that the preload as such is not an index of the preload responsiveness, but it doesn't indicate that measurement of preload are not interesting for other things. I mean, when you have an increased preload or raised filling pressures, this means that indeed for diagnosing the heart dysfunction is something very important. But for predicting the response to fluid is something totally different. So if we think at this curve here, indeed for filling the heart, the extremes are very important, but in between, which is most of the patients we see, we are in a gray zone, we cannot really predict the things. But again, measuring the volumes or measuring the pressures are very important, because when you have here a relatively high stroke volume with a middle range pressure or volume, this means that the contractility of this patient is much better than this patient here with a low stroke volume and the same preload. So this is used to assess the way the cardiac function is working or not. And of course, we know that we use these dynamic indices to predict responsiveness much more than any others. So that's why this is indeed recommended by several scientific societies. I'll pass rapidly about this. Contractility, this is much more complicated, because indeed we can use several things. Biomarkers, troponin, not really reliable here. Cardiac output itself is not a marker of the contractility. I just show you the different curves, and indeed, you can have, if you push sufficiently high, you can have a relatively preserved cardiac output, especially if heart rate is quite high, even though the contractility is depressed also. So for evaluating the contractility, we have only 3 correct devices that can be used at the bedside, which is echocardiography, pulmonary artery catheter, and transpulmonary thermodilution. And I think this is really very important, that it is very difficult to guess what is the contractile function with just the clinical signs or with biomarkers or even with cardiac output at the bedside. I don't know if you wish to comment on this.
No. I agree. Maybe I can add some. You said tachycardia could be responsible for normal cardiac output in spite of cardiac dysfunction or hypovolemia, etc. So it is important, if you have cardiac output, just to measure, it's not difficult, stroke volume, to calculate stroke volume. because it can indicate about what is the real volume which is ejected bit by bit. So it is important just to have this notion, but you said this, because sometimes we have the impression that cardiac output is okay, but stroke volume is low, only because of
And
tachycardia.
especially in patients with cardiac shock, sometimes you are a little bit misled by the fact that they just maintain the cardiac output. This is why they survive. They're not yet dead at the time you see these. But when you realize that they have this relatively lowish cardiac output, but with a heart rate on 120 or 30, then you realize that stroke volume is only 20 or 30. And these patients, if you don't do anything, these patients will be dead tomorrow. So with ECO, we have a lot of things we can evaluate. I will not go into the details there. With others, we have indeed this possibility to evaluate some other factors. I will not go into the details there. But perhaps the most important aspect is what do you do with the different variables you measure. And this is something we need to pay attention, because indeed, some may say we use protocols. And I strongly argue that this is not the best way to go. I mean, we have, of course, the evidence from the SCVO2 that it doesn't work. We have some evidence from the previous Gattinoni trial and others, and just using these kind of protocols is not good, and we probably need to go for the individual aspect. Perhaps still a word of caution on these goal-directed therapy. I mean, I saw that some people voted for, I don't care about SVO2 because it doesn't improve outcome. Well, these were not trials performed really in very severe patients. Remember that 20% of these patients with so-called septic shock were not admitted in the ICU and were not dying. 20%. One patient every 5 patients included in these trials were not going into the ICU. This means that they included people in the street and they call this septic shock and they measure SVO2. Okay, no change. We can walk again in the street of Hong Kong. So this is something we need to be cautious about, and it's valid in the 3 trials. I mean, you can see same proportion of the control patients were going not in the ICU. And this is something which is indeed a little bit a problem. The second, of course, problem was the inclusion rate. Only half a patient per center per month in most of the trials. This means 6 to 12 patients per year in your center. If sepsis is a problem for 6 or 12 patients a year in your center, I don't think we need to talk about it. So probably concept, physiological or physiological concept remains valid. Patient identification is crucial. Providing to everybody is dangerous or not nonsense, at least. And we have to do something else. Individualized medicine is probably the way to go. And for this, I would like to discuss now the interest of the perfusion pressure target. And for this, we have this trial for which Jean-Louis Teboul contributed, where indeed there is no difference in the outcome, but some patients had some benefit. Some patients also had some side effects. And so there are different ways to approach this. Again, the protocolized approach is, my patient is hypertensive, I go for a higher blood pressure. I would not go in that direction. I mean, I would prefer to have a higher blood pressure trial, which is I test the system and I see if my patient responds yes or not. Because I know that if I go for higher pressure, I will give more vasopressors, I will have more side effects potentially. And so I would expose my patient to potentially more side effects only if I know that I have some benefits. And for this, I would prefer to go for this kind of trial with our other chairman here, was indeed looking at the renal perfusion itself. And so this can be done by the renal Doppler perhaps, it can be done by looking at urine output, it can be done at maybe some other factors. And if you go for a higher blood pressure and you have some improvement, I would suggest to continue there. If you do not have benefits, I preferably go back to the other one. Of course, it's not a 10 minutes trial like the free challenge. It should be 2-3 hours trial just to see, of course, the results of this.
I totally agree with you. This is what I call the norepinephrine test, for example.
Exactly.
And you look at. But just I want to make a comment about the study by ASFA, the New England Journal study, because I hear a lot of times that you have a price to pay because in patients with chronic hypertension, we found a better renal function with the high MAP, which is not very high, but which is called the high MAP.
Is that increased urine output? So
We are
defining improvement. So you're looking, your endpoint is an increase in urine output.
the endpoint. No, it's difficult because many patients had a renal failure. We had 74% of patients with renal failure at the beginning. But my point is, in this group of patients, there was no more tachyarrhythmias. I look at the results because I was one of the person responsible for the results. In this group of patients, the chronic hypertensive patients with high MAP, there was no difference in the rate. No, believe me.
Yes,
If you
but-
don't believe me, okay.
Jean-Louis, there is no echocardiography in the trial.
No.
We looked at the ECGs. Yes, I looked personally.
Yes,
This
I
was
know
my
this,
contribution.
but there is no echocardiography. So
Okay.
I
But
completely
know-
agree with
okay,
Daniel
okay.
that it could be very tricky to leave
Yeah,
a
no.
patient
Just to say
during
that there was no
3 days at this level. And I completely agree that we have to test it and to
I
evaluate.
agree with this, but just
So I will be the chairman to try to be quiet about this.
We work in the same hospital.
I have a question. I still didn't understand what you look at. Because you say, I do a norepinephrine test and I look. But you look at what in the patient?
this is a good
So-
point, of course.
So in this test here, it was done indeed by looking at the improvement in renal perfusion.
But at the bedside,
So this is. So my personal view would be to look at the urine output in the short term, because indeed at the bedside doing these kind of things is a bit more complicated. It's just the proof of the concept that indeed some patients improve, some patients do not improve, and also that the level at which you may have these things is quite variable. I mean, some patients may have needed to go to 75, some other to 85, and so it's really individual target which has to be determined. In trials, it's like this one, it's very easy to do because you do specific measurements without doing anything. But the problem is you do not know exactly what is a good level now, what is a good level in 3 hours, what is a good. So I think that indeed doing it once is probably reasonable. You can repeat it if you wish, but I would do. Usually what I do is once and I see urine output. It may not be the best marker. Maybe some would prefer to look at the biomarkers, but it will be something at least to do at the bedside.
Yeah, we talk about tachyarrhythmia and lack of tachyarrhythmia. We have patients with tachycardia. What's the level of tachycardia that you would tolerate? How long, and what do you do to try to normalize the heart rate?
Wow. So this is something totally different.
Only 1 minute.
In 1 minute. So the tachycardia, I mean, is somewhere between 100 and 120, where I'm concerned. Over this, I will definitively try to do something to decrease tachycardia, but not by giving directly beta blockers. I mean, the first step will be, am I sure that I cannot do something to just improve stroke volume to decrease the reflex tachycardia? Of course, I will pay attention to temperature of my patient, to pain and anemia, of course, as a triggers. But then the question is there room, yes or not, for beta blockers in that patient? And for this, I again look at the echo and at the contractile function. In a patient with impaired contractile function, often it will be very difficult to have a room for beta blockers. If your patient is with a hypercontractile and tachycardic, yes, in these conditions you may consider beta blockers.
What about digoxin?
Well, digoxin are rarely used at this stage. I mean, in patients with Cardiac shock, yes. In patient with sepsis, not used at this stage.
Daniel, just I'd be interested to know your clinical experience, because I can tell you mine. When I've used beta blockers in septic shock with echo, it's been universally a disaster, and I wish I hadn't done it. So, have you been in a position where you think there's been real benefit, or?
In hypercontractile patients, yes.
Yeah, that's
the
the only group, but that's so rare.
That's the sole group where I give it. The other one, I even don't dare to do it.
I totally agree with you. And you also remember that in the Morelli paper, cardiac dysfunction was excluded.
Yeah.
Excluded.
Yeah, and a Chinese group also nicely showed that the patient who will increase the stroke volume in response to beta blockers as a patient with preserved cardiac function assessed by one index of movement of the mitral valve. The other one decreased cardiac output.
So maybe it is time for cardiac arrest patient? No?